Dhanushya, visible, you can proceed.
Very good evening, sir. I am Dr. Dhanushya from Rajamudaya Medical College. I am doing my final year post-graduation. Today I will be presenting on a preterm with hypoglycemia and jaundice. Baby Geeta, a 7-day baby boy, born to a 23-year-old trainee mother of non-consanguineous marriage from Chidambaram, was admitted in our NICU for respiratory distress since birth. The informant was the mother and her reliability was fair. History of presenting illness. The baby was born on 27th July 2022 at 9:45 p.m. by normal vaginal delivery at RMCH at 32 weeks of gestation with a birth weight of 1,420 grams. The baby cried immediately after birth. The baby was admitted in our NICU for respiratory distress since birth and for preterm care. The baby was initially treated with nasal oxygen and IV fluids. The respiratory distress settled by 6 hours of life. On day 1, the baby was started on expressed breast milk through Paladai after the distress settled, and the KMC care, Kangaru mother care was initiated. On day 2, non-nutritive sucking along with Paladai feeds were started. On day 3 of life, the baby had lethargy with poor suck. CBG monitoring done was low, for which the glucose infusion was started. Glucose infusion was continued for 2 days and then stopped. On day 4 of life, the baby had history of yellowish discoloration of skin, for which phototherapy was given for 2 days. There was no history of convulsions, no history of abdominal distension or vomiting, no history of fever or cold peripheries, no history of cyanosis. The baby passed urine and meconium within 24 hours of birth. Antenatal history. The mother was a preemie and her age of menarche was 13 years. She had a regular 3/28-day cycle. The age of mother at marriage was 22 years. No preconceptional folic acid intake. The mother conceived spontaneously 6 months after marriage. Her last menstrual period was 15th December 2021 and her expected date of delivery was 22 September 2022. The pregnancy was confirmed by urine pregnancy card test at 45 days of amenorrhea. She was registered and immunized. First trimester, there was no history of hyperemesis gravidarum. There was no history of fever with rash or post-auricular swelling. There was no history of bleeding per vaginum. There was no history of any drug intake or radiation exposure. There was no history of any exposure to pet animals. History of folic acid intake was present. Dating scan done was said to be normal. Second trimester, quickening was felt at 5th month of gestation and the mother continued to perceive fetal movements regularly thereafter. There was no history suggestive of gestational diabetes mellitus, pregnancy-induced hypertension, or hypothyroidism. There was no history of bleeding or draining per vaginum. There was no history suggestive of urinary tract infection. Iron and folic acid tablets were taken. 2 doses of tetanus toxoid was given at 5th and 6th month of gestation. Anomaly scan done at the 5th month was said to be normal. Third trimester, the mother continued to perceive fetal movements. There was no history such of gestational diabetes or pregnancy-induced hypertension, no history of bleeding or draining per vaginum. There was no history suggestive of UTI. The growth scan done at 7th month of gestation was said to be normal. Pre-pregnancy weight was 55 kg. Weight gain during pregnancy was 6 kg and total antenatal visits were 5. Natal history. The expected date of delivery was 22nd September 2022. The mother was admitted in RMCH in view of abdominal pain for 2 hours and draining PV for 1 hour on 27 July 2022 at 9 a.m. The mother had a spontaneous onset of labor, delivered an alive male baby with birth weight of 1,420 grams by normal vaginal delivery 10 hours after admission on 27th July 2022 at 9:45 p.m. The baby cried immediately after birth. The liquor was clear and not foul smelling. The total duration of labor was 12 hours. There was history of 1 intramuscular injection given to the mother on admission. Postnatal history. The baby was admitted in NICU for respiratory distress since birth and for preterm care. The baby was initially started with nasal oxygen and IV fluids. The respiratory distress settled by 6 hours of life. X-ray done was said to be normal. On day 1, the baby was started on express breast milk through Paladai along with the Kangaru mother care After the distress settled, on day 2, non-nutritive sucking was started along with Pala day feeds. On day 3 of life, the baby had lethargy with poor suck and sugar monitoring done was low, for which glucose infusion was started. Glucose infusion was continued for another 2 days and then stopped. Feeding was continued and direct breastfeeding was established on day 5 of life. On day 4, the baby had history of yellowish discoloration of skin, for which phototherapy was given for 2 days. At present, the baby is exclusively breastfed, feeding on demand around 6 to 8 times per day during the daytime and 3 to 4 during night. Each feed is for about 20 to 25 minutes from one breast at a time. The baby sleeps for around 1.5 to 2 hours after each feed. The baby passes urine 6 to 8 times per day and passes stools 3 to 4 times per day. The baby gets kangaroo mother care around 6 to 8 hours per day. Birth dose vaccination was not given. Family history, there was no history of preterm deliveries in the family. There was no history of anemia, jaundice, or blood transfusion among family members. Socioeconomic history, father's age was 30 years and he was farmer by occupation. Mother's age was 23 years. She was a housewife. It was a non-consanguineous marriage. Both completed high school education. According to modified Kuppuswamy scale, their family belonged to upper lower class. Summary, a 7-day-old baby boy who is a moderate preterm with a postmenstrual age of 33 weeks with a very low birth weight of 1,420 grams, born of spontaneous preterm labor by normal vaginal delivery with no other antenatal complications, presented with respiratory distress since birth, probably due to transient trachepnea of newborn, with symptomatic hypoglycemia, probably due to prematurity or sepsis, and on day 3, and neonatal jaundice on day 4 of life.
Okay. Good, doctor. Yes, have been elaborated very nicely. Your presentation is very nice, and you have been elaborated all the things in a good manner.
Thank you.
So here I want to look. Where is the pathology? Where is the pathology? What is the reason for the preterm?
Sir, this baby, mother actually did not have any antenatal risk factors. The delivery was a spontaneous delivery, and the baby was born as a moderate preterm, 32 weeker. So the main pathology will be the preterm prematurity of the baby, sir.
Yeah. I'm just asking, what is the reason for the prematurity? What is the reason for the prematurity? So, in other words, what are the reason for the prematurity? What are the reason for the premature?
The mother can have a pregnancy-induced hypertension, or the mother can have uterine anomalies. There can be short cervix in the mother. Then chorioamnionitis or UTI may be a reason for preterm deliveries. Then fetal factors,
Okay, fine, good, very good. And what is the reason for this baby?
The mother had spontaneous labor pains along with the rupture of membranes.
Fine. That means first is pain is there or membrane rupture is there?
First pain was there, sir.
So first is pain is there, then only the membrane. Before admission, 2 hours before the admission, the pain is started, and 1 hour after the admissions, the mother had a membrane rupture.
Yes,
and
sir.
membrane is like it's not false swelling and another issue. And with this, you can also add on to like whether to look at whether there is some perinatal infections like urinary infections like UTI, suggestion of any burning maturations, or history suggestion of any discharge, vaginal discharge with itching, or any false smelling discharges, or any fishy odor like discharges, or itch in the genital tract. So it gives more towards bacterial vaginosis or UTI, which may contribute to one onset of this preterm labor or premature rupture of the baby. So if this added to that your history, we can, because whenever the main objective of any history taking is to pinpoint the thing is where is the pathology and what is the pathology, whether that pathology is gone for any complication. So if it's a preterm, we have two parts. One is an searching an etiology for a preterm, and another part is an how the preterm itself have issues related to preterm things. Everything you should get it from that history itself. So if you concentrate on if you add on that history, that much more gives enlighten in much better way. So like perinatal infections might be a reason of it. So in a broad manner, only three things, whether it is an history related to, we already stated that there is no family history of prematurity. It's very good one. And it is in 34 weeks. So cervical and cervical factors won't be much issues for that. So either it is in preterm labor or a preterm premature rupture of the membrane. It is in preterm labor. Then what is the reason for the preterm labor? You must able to come to, because no other history like pH, GDM, and no other history is suggestive of anything attended to the onset of preterm labor. So if you add on that history, it is much more good important. And two thing is, what are the reason for that respiratory distress for this baby? What would be the reason? What are the reason for the respiratory distress in a preterm baby? And what would be the reason for the respiratory distress for this baby?
Respiratory distress in a preterm baby, the most common cause will be the respiratory distress syndrome, sir. The other causes can be transient tachypnea of newborn, congenital pneumonia, pneumothorax, apnea of prematurity can also be a cause. In this baby, transient tachypnea of newborn, because the respiratory distress settled with nasal oxygen and it did not require any further continuation of oxygen, or the distress did not prolong for long.
Super. So okay, it's a commonest cause would be in a TTN or an RDS or an US, early outcome sepsis. This is for top three cause for respiratory distress for any preterm. It's very good.
Was the child given any antibiotics?
Sir?
Was the child given any antibiotics?
The child was started on empirical antibiotics, sir, on day 3.
Now this child has started on empirical. You must understand, send this question. This pregnancy is not normal. This ended up prematurely, with preterm labor.
Yes, sir.
So you need to ascertain the cause for that preterm labor.
Okay, sir.
And one suspicion that is going through the clinical course is the sepsis. Now you are saying that it could be TTN because it is settled within 6 hours. This could be still infection that has responded to the antibiotics and settled also. Okay.
Okay, sir.
So we nowadays don't use empirical treatment sepsis. Okay. We call it presumptive sepsis. So the terminology of empirical is gone. We call it presumptive sepsis. Here you presume there is sepsis because of preterm labor, because of hypoglycemia, lethargy, which because it's in your care. This baby is going for hypoglycemia while on your care, feeding regimen, which means there is increased metabolism that is consuming more glucose. And one of them is sepsis. Okay, so this baby has probably responded to antibiotics and the respiratory distress is settling down. So you can't label this as simply TTN also.
Okay, sir.
So your other sepsis screen would give you clues whether you have dealt with sepsis or TTN. Good.
Okay, doctor. And you've been told that the respiratory distress is started and has been improved within 6 hours of life. Can you tell what are the respiratory support the babies has been given that baby has been supported with? What are the respiratory support?
For this baby.
In other words, what are the respiratory supports can be used in a baby with a respiratory distress?
Continuous positive airway pressure is the best mode, sir. CPAP.
So you just tell what are the respiratory supports available for this respiratory distress syndrome to support, and when to use what are the which respiratory supports.
If the baby is born,
For example, so what are you first? You tell what are the respiratory supports available for the treatment of respiratory distress.
Nasal prongs, sir. Then
Good.
Then CPAP, bubble CPAP.
Good.
Non-invasive ventilation.
What is it?
HFNC, humidified high frequency nasal cannula, HFNC.
Okay, and then what?
Then invasive mode of ventilation, sir.
Fine. Okay, then tell when will you start oxygen for this? For which baby needs an oxygen? Which baby needs an CPAP? and which baby needs an ventilation? How will you decide this?
Less than 28 weeks,
Whether
the baby
this
has distress at
respiratory
birth,
support,
we directly
doctor, whether this respiratory support is decided by the gestation age,
No,
or
sir.
by any other thing?
By scoring, sir. By the
Yeah, good, very good. Good. What scoring?
for preterm, we use Silverman Anderson scoring, sir.
And what are the scorings you know what?
Silverman Anderson scoring, a Downey scoring, sir.
So which is best? Silverman or
For preterm, Silverman Anderson score is better, sir.
okay, you have any idea that which one is newer thing, which one is an older scoring system, down score or an Silverman? Or which scoring have a correlation with partial pressure of oxygen and pH? Other students can also answer.
Silverman Anderson scores.
Silverman Anderson score?
So, yeah, in that
My
score we can
question
see
is,
both.
which, you told two scoring system. One is a down score and another one is an Silverman Anderson score. Which score have a correlation with the partial pressure of oxygen and pH? Only two scoring system. One is in Downs and another one is in Silverman. So my question here is, which score have a correlation with partial pressure of oxygen with and pH? Then that score is only an validated score. That score is only and repeatedly we can use without any bias. Which score?
Downey score.
Good. Why?
Because we can see cyanosis in that score, sir.
Not only cyanosis, this score only we've been validated for it. Actually, this score is only we can use an FiO2. So in the Anderson, Silverman Anderson, if you want use an FiO2 requirement, here we can use an FiO2 requirement to assess the cyanosis. How is the cyanosis is in the room air or less than 40% of oxygen or more than 40% of the oxygen. So you can able to grade within measurable things like FiO2. So this is the latest one when compared to Silverman Anderson score. It has been down score has been good correlated with an good correlation with an what is called pH and partial pressure of oxygen. Okay, very good, fine, good. You are told that we can use a scoring system to assess the respiratory support. Which respiratory support you want to give? Okay, fine. How? What are the scoring limits with which we can able to give that oxygen, or we can give an CPAP, or we can give an ventilation, or we can give an surfactant?
If the score is more than 7, the baby needs invasive modes of ventilation, sir.
Okay, fine. More than 7, we need a baby needs a ventilation. Very good, super.
4 to 6, the baby, we can start the baby on CPAP, sir.
Anything more than 3, we can put it on CPAP. Anything more than 6, we can put it on ventilation. That's good, very clear. Less than 3, even less than 3, we can use an oxygen, but we can use better going for a blended oxygen. Blended oxygen is very good. If you blended oxygen, not an very simple oxygen. Rather than simple oxygen, go for a blended oxygen. And if you titrate an FiO2 requirement between 30 and 40, if anything, baby is less than 30% oxygen requirement, means baby doesn't need any surfactant. If any baby needs more than 30% of the oxygen requirement, definitely this baby going to need some surfactant. Okay, good, very good, and you have been answered very well. Good. And my another question is, this is regarding respiratory distress. And another question is, you told that baby is on KMC on day 2 itself.
Yes,
Day 2, you told that the baby is on KMC from day 2 itself. And what are the components of the KMC and what are the advantages of the KMC? I think other students can also answer to these questions. What are the components of the KMC, kangaroo mother care, and what are the advantage? And why it is still as kangaroo mother care? Because kangaroo care can be given by father or even aunt or grandmother can give it a kangaroo care. Why it is called as kangaroo mother care? Number 1. And number 2, what are the components of the kangaroo mother?
So the KMC can be provided by any of the family members, but since the mother, KMC, if the KMC is given by the mother, it will increase the efficacy of breastfeeding. That
Super. Good. Very good.
then maternal and baby bonding will be improved if
Okay. What are
KMC
the components? What are the components of the KMC?
The baby should be positioned in front facing, and the head should be turned to the right side, to any side. Then the baby should be placed in a frog position, and the baby's abdomen should be placed on the mother's abdomen, and the then the mother should have a front open dress, and the baby should be covered with a cap, socks, and mittens. With the baby also should be dressed with a front open dress.
One of the first components is skin to skin care. Okay, then
the head should be turned to prevent.
What you're telling is about putting it in a skin to skin care. Okay, one component is skin to skin care, and another one is second. So exclusive breastfeeding, and third one is an early discharge. Because once the mother is putting the baby on this KMC, the mother will be having it very confident, and it have much more bonding. It increases the self-confidence of the mother, and he can able to discharge it earlier. So okay, fine, good. And what are the advantages of KMC? Kangaroo mother care.
Weight gain also will be there.
Pardon?
Weight gain also will be there.
Weight gain, good. Then
it prevents against sepsis, provides warmth to the baby.
Super, good. Temperature management, temperature maintenance, and sepsis reduction of sepsis. Then
and also promotes bonding between the mother and the baby.
Yeah, and it also prevents apnea.
Yearly discharge from.
Yeah, it also prevents an apnea. And also, it is called family-centered care, which has been booming in newborn, where we involve the family members to give a care of preterm babies. Because the unit, if you're having a unit having much more involving taking care of small preterm babies, if you introduce in KMC in an effective manner, then we can able to discharge more babies, and the outcome will be much more good. So good. And another question is regarding your INC taking. Third day, you said that baby is having a lethargy. What would be the reason for the lethargy? Or in other words, what are the reasons for the lethargy in an preterm?
Hypothermia, hypoglycemia.
Good, very good.
Sepsis. Hypoglycemia, hypothermia, sir.
Good.
Then sepsis.
Good.
Then meningitis.
Okay.
Acidosis.
Okay, anything else? Yes. So it's like hypothermia, hypoglycemia, sepsis. These are the things we need to eventually address, and make sure that this temperature management is because I want to ask one thing is, during this 1 to 3rd day, the babies in the warmer, or babies in with the mother in KMC?
Baby was in the warmer inside the NIC only, sir.
Any other possibilities that baby having a reason for lethargy other than this?
Other possibilities may be intraventricular hemorrhage.
Intraventricular hemorrhage. Okay, baby maybe lethargy, but definitely they will have a seizure, and they will be in posturing, and definitely they will having a seizure. If it is baby is having in sepsis, that also, because already baby is receiving an antibiotic, as you told, that without stepping up of any antibiotic or without any stepping up of any intervention, the baby is not able to, what is it? Baby is not getting improved naka, then we can think of an sepsis. Even though if you have been stepping up of an antibiotic means, okay, fine. And other possibilities. So you have told hypoglycemia, hypothermia, hypoglycemia, hypothermia, sepsis, just meningitis, IVH, then
Hypoxia can be reason.
hypoxia.
It can cause lethargy.
Pardon?
Hypoxia can cause lethargy.
Now, what is the reason for hypoxia? Is it common cause or common? Okay, we'll go with an one by one. So any babies, if on starting on breastfeeding and being deteriorated and continues to get deteriorated, and not baby putting it in the track, then we can think of an sepsis would be in first possibilities, IEM should be in first possibilities, or an even IVH. If the baby is having an lethargy and seizures, what are the possibilities are there?
Intraventricular hemorrhage, meningitis,
Good, very intraventricular hemorrhage. Then
meningitis,
meningitis. Then
electrolyte abnormality,
IAM.
hypocalcemia,
even
hypoglycemia.
hypoglycemia, even IEM. So these are the things we have lethargy as well as a component called and seizures. Only lethargy, you give a priorities to them, hypothermia, hypoglycemia. And okay, some form of sepsis, mild sepsis.
In a nursery with open care radiant warmer system, undue heat also, hyperthermia, because babies may get overheated up, and that is one of the most common cause of lethargy in a nursery which is practicing open care system. So that also you have to give that what Dr. Sendil reiterated, temperature regulations, if not proper, and you are exposing the baby to high temperatures and warmer, that causes lethargy in preterm babies.
Okay. Okay, doctor. Okay, proceed. Saravanan sir, you can also.
So you told about pregnancy, during time of pregnancy, the mother gained weight of only 6 kilos. Is there any correlation between your findings with the pregnancy weight? Or you can trust whether birth weight or what should be the normal birth weight during the pregnancy?
Not audible, sir.
Primary mother, right?
Sir, not audible, sir.
Sir, you're not able to hear, sir.
You told about only 6 kg mother has gained weight during the pregnancy, right? 6 kg, only 6 kg weight gained during the pregnancy.
Yes, sir.
Is there any correlation between your findings and these weight gain? Hello.
The baby was hello, sir.
Hello.
Sir, the baby was delivered at 32 weeks of gestation.
Okay.
The maximum weight gain will occur in the third trimester.
Okay.
So this.
Okay. Is there any whether it could be a predisposing factor to be a baby born with preterm or going for sepsis or IVF?
Yes, the malnutrition also can be a cause of prematurity, sir.
Okay.
Maternal anemia, maternal malnutrition also can be a cause.
Okay, proceed. You can proceed.
General examination. Posture. The baby is lying on the warmer with flexion of upper and lower limbs. The baby is awake and moving all four limbs symmetrically. The cry and activity is good. The baby is pink, no pallor, no cyanosis, which is measured in the right axilla. Pulse rate was 126 per minute, regular in rhythm, no specific character, no brachiofemoral delay, peripheral pulses were well felt. The BP was 56 per 38, measured in right upper limb. The mean arterial pressure was 32 mmHg in the right upper limb. Respiratory rate was 42 breaths per minute. The saturation was 98 in right upper limb and 97 and 98% in the left, right and left lower limbs. The capillary refill time was normal. Anthropometry, the birth weight was 1420 grams, which was appropriate for gestation. and the present weight was 1260 grams with a weight loss percentage of 11, which was acceptable, and the length was 42 centimeter, which was between the 50th and the 90th centile, and the head circumference was 30 centimeter, which was on the 50th centile. Head to foot examination. The hair was thin, sparse, and
excuse
sticky.
doctor.
Yes, sir.
So, what has been with this anthropometry measurements? What is their inference?
The baby was appropriate for gestation age, sir. And there was no microcephaly.
So what is meant by appropriate for gestation age?
If the birth weight lies between the 10th and the 90th centile, we call it as appropriate for gestation, sir.
What is meant by SGA?
If the birth weight is less than the 10th centile, it is called small for gestation, sir. Or 2 standard deviations below.
What is meant by IUGR?
IUGR is the intrauterine, the fetal growth restriction will be there, and the fetal growth trajectory, that curve will have a fall, sir. The measurements will be the fetal growth trajectory will be will fall, sir.
See, actually, with this we can able to tell about only an things called an SGA. That's all.
Okay.
To say an IUGR, either you can, what are the, how can you can diagnose an IUGR?
By using
You can
pondral
use
index.
a pondral index.
Then
By maternal antibody.
there is a things called an CAN scoring, clinical assessment of nutrition status of a newborn. So CAN scoring, and another thing is called an pondral index. Okay, proceed.
Head to foot examination. The hair was thin, sparse, and sticky. Head was normal in size and shape. Anterior fontanelle was open and at level, size 2.5 cross 2.5 centimeter. The posterior fontanelle admitted tip of little finger. There was no cephalohematoma, caput succedaneum, or subgaleal bleed. No facial dysmorphism. The eyes were normal. Ears were slightly curved pinna with a slow, soft recoil. Oral cavity, there was no cleft lip or cleft palate. The neck was normal. Skin was smooth with thinning of the lanular hair and visible veins. The breast bud was 2 millimeter. Umbilical cord was dried. There was no divarication of recti. External genitalia, both testes descended with few rugosities. Limbs, limbs were normal with the IV cannula on the right forearm. Anal orifice was normal. Spine was normal. According to new Ballard score, it corresponded to 32 to 34 weeks of gestation.
Okay.
Cardiovascular system exam.
Yeah.
One minute. This baby you examined by keeping under warmer, pa?
Yes, sir.
Now, now does the warmer unit have a temperature probe and continuous monitoring of temperature?
Yes, sir.
Now, why is the need to use a axillary temperature, another thermometer to use a axillary temperature when you can just measure from the temperature probe that is available in the warmer unit itself? That's because some practices don't die. No? You get a continuous monitor of temperature. All you need to do is connect the probe to the baby. Your warmer unit is going to be on when you are doing a clinical examination because you keep the baby warm while clinical exam. So there is no necessity to superfluously use one more thermometer to put in the axilla when you have a more sensitive thermometer with the warmer unit itself. So you can say it's skin temperature of the baby instead of putting it as axillary temperature. Okay.
Okay, sir. Okay, sir.
Okay, proceed.
Cardiovascular system examination. There was no precordial bulge. Apical impulse was felt in the fourth intercostal space, lateral to the midclavicular line. S1 and on auscultation, first and second heart sounds were heard, and there was no murmur. Respiratory system, the chest was symmetrical, movements equal on both sides, air entry equal on both sides, and there were no added sounds. Abdomen, soft and non-tender. Umbilicus in midline, there was no discharge or redness, no organomegaly, and bowel sounds present. Central nervous examination, posture, baby was lying on the warmer with flexion. First cranial nerve, baby turns head to the mother's milk. Second cranial nerve, pupillary reflex present. Third, fourth, and sixth nerve, the baby moves eyes in all directions. Fifth, ninth, 10th, and 12th nerve, sucking, swallowing, and rooting reflexes were present. Seventh nerve, no facial asymmetry or deviation of angle of mouth. Eighth nerve, startle reflex was present. Motor examination, posture, the flexion of both upper and lower limbs. Tone or passive movements was appropriate for the gestational age, and power was 3/5 in all. Knee jerk was present on both sides, and bilateral plantar was extensive. Neonatal reflexes, sucking and rooting reflex was present. Palmar and plantar reflex was present. Morose reflex was present but incomplete and symmetrical. Startle reflex was present. Stepping and placing reflex were present. Asymmetric tonic neck reflex was absent. Spine and cranium normal.
Were this neurological examination done at the time of admission or at the time of discharge or later?
Sir, this was at the seventh day of life, sir. When I examined the baby, you mean? Not
On
at
seventh
birth.
day, that is on time of admission.
Yes.
Now here is a
No, sir,
baby
not
that
on
is
time
getting
of
admitted
admission,
with
sir.
lethargy, poor feeding, respiratory distress, no?
Not at the time of admission. Yes, sir. This was at the
Yeah.
seventh day
You
of
don't
life.
subject a sick baby to a
This
neurological
was at the seventh day
examination.
of life, sir.
That is, this baby was admitted to you on which day?
So this baby was, since birth, it was admitted to us, sir.
Okay, seventh day after
Since
is
birth,
recovered from
this baby
respiratory
was
distress.
with us,
Okay,
sir.
fine.
Seventh day after.
Okay. In your clinical examination, are you able to see something more visible in the baby? So you can see that visible wasting all over the body. This baby is lacking fat and muscles. No, it is having a very loose fold of skin everywhere. So what did this baby could be?
Can be an IUGR baby.
Yeah, this is an
IUGR.
IUGR. So now there probably some reason existing in the pregnancy itself that caused this baby IUGR. That probably is responsible for this preterm labor also, because nature designs, if once the conditions are unsuited, the delivery happens for the safety of the baby. So we now something is missing in this, okay, in the antenatal history, that we have not unraveled the cause for the preterm labor, the cause for this IUGR also. Proceed.
Yeah. Yes, doctor.
Diagnosis. A 7-day-old male baby who's a moderate preterm of gestational age of 32 weeks with the postmenstrual age of 33 weeks, which was appropriate 120 grams with a present weight of 1,200 tachypnea of newborn with symptomatic hypoglycemia, probably due to prematurity or sepsis with the neonatal hyperbilirubinemia.
Now you also must include IUGR, that this baby is definitely looking IUGR, and you have to definitely include IUGR because the treatment will also vary and the follow-up will also vary. The prognosis is also different when compared to AGA preterms of 32 weeks. This baby recovers from 32 weeks without much respiratory distress because of IUGR. Did the
Okay,
baby
doctor.
and mother receive any antenatal corticosteroids?
Yes, sir. The mother received 1 dose of
Only one
steroid.
dose.
One
So the
dose.
one dose is not going to have that adequate effect, but still baby recovers without hyaline membrane disease or RDS. That is because of the IUGR.
Okay. Doctor, the thing is, what are the perinatal interventions which makes a baby to preterm baby to improve a good neonatal outcome? What are the
Antenatal
perinatal
steroids, sir.
interventions to improve the you please catch the questions, clearly catch the questions. What are the perinatal interventions for good neonatal outcome, especially for a preterm baby?
Resuscitation should be gentle, sir.
See, perinatal
Uh,
interventions means one is
See, one of the
antenatal
things Dr.
interventions.
Sindhu is asking, administering antenatal corticosteroids is a perinatal intervention. What are the other perinatal interventions that are available? This question.
magnesium sulfate can be given.
Sulfate.
So, when it is indicated, what is the age limit?
When it is less than 34 weeks,
Less than 32 weeks or less than 1.5 kg, we can use a magnesium sulfate. What is the advantages of using it?
it can improve neurological outcomes.
Okay, fine. One is an magnesium sulfate, and another what you told it is an antenatal corticosteroids. Okay.
Antenatal corticosteroids.
Antenatal corticosteroids. Okay. What is the guidelines? Indian national guidelines on antenatal corticosteroids. Indian national guidelines
Dexamethasone
on
is
antenatal. Yeah.
Dexamethasone is preferred, sir. It is given 6 mg 12th hourly for 4
No,
doses.
first of all, you must tell who are the candidate indication to whom you are going to give it, where to give,
Eligibility for
when to
antenatal
give, when to give,
than
everything you
less than
should tell.
34 weeks.
24 to 34 weeks of gestation, sir.
Okay. 24 to 34 weeks.
34 weeks of
34
gestation.
Okay, fine. Then
Sir, if it is less than 24 weeks also we can give, sir. Depending, we have to decide whether the baby
see,
would
I am just
have
asking
a
in
good
Indian
outcome or not.
national guidelines. I am just asking in Indian national guidelines. I am not asking about recent guidelines on consensus on antenatal corticosteroids. Indian national guidelines is very clear that it is given in 24 to 34 weeks, and especially within what are the steroids?
Dexamethasone is given, sir. 6 mg.
Why dexamethasone? Why
It is
dexamethasone? Why dexamethasone by India?
Because beta-methasone acetate and phosphate is given in the ratio of 1:1, sir. That beta-methasone acetate is not available in India, so dexamethasone is preferred, sir.
So in beta-methasone, phosphate is only available in India, but all studies has been done within beta-methasone acetate and phosphate. So in India, if you are giving an beta-methasone phosphate, its TF is very less. So efficacy is not being validated. So in India, Indian national guidelines clearly says only in dexamethasone can be given to our babies, so to our mother, okay, for an antenatal mother from 24 weeks to 34 weeks. Wow, how long this, what is the dose?
6 mg 12th hourly for 4 doses, sir.
Okay, then what is when the effect is going to start? When the antenatal steroids effect will be, advantages will be?
It should be given at least 24 hours prior to delivery, sir.
No. See, if I started giving an antenatal corticosteroids today for 48 hours, the effect starts after 24 hours after the last dose, and it lasts for only a week. So
For a week.
actually, the effects of an antenatal corticosteroid starts after 24 hours of the last dose, and it lasts for a week, only a week. Okay. So even a single dose may give some advantage, but actually the real advantage is only after a full dose. That means 4 doses after the 24 hours after the 4 doses. Number one. Number two, what are the benefits of giving an antenatal corticosteroids? Why we are giving much more importance for an antenatal corticosteroids?
It prevents respiratory distress syndrome, necrotizing enterocolitis, intraventricular hemorrhage, and there is reduced risk of mortality, and some studies suggest that it reduces early onset sepsis also.
So it's only and mainly the decrease the mortality and decrease all morbidities related to one preterm. So that's a very big boom that everyone is thinking. So this is an antenatal interventions. The perinatal, one is antenatal and another is natal. What are the natal interventions to improve the outcome of a preterm baby?
Delayed pot clamping, sir.
Preterm.
If
Preterm.
the month
Cover up with a plastic wrap if the baby is
For a preterm, mama.
preterm.
Term, it's okay. It's we have very clear cut evidence to say that delayed cot lamp is going to give an much more importance. Preterm, the evidence is emerging, but still now we will wait it for it final word to come. For an preterm, thing is we need to having and do using an delivery room temperature management. Number one. Number two, early CPAP. Need an TPS resuscitator in an delivery room. And transporting system. How the baby is being transported in a temperature, full control temperature to the NICU. It's another factor. And the fourth one is then whenever we are dealing with a micropreemie less than 1.5 kg or less than 1 kg baby, use of an plastic bag, so which improves an outcome of an micropreemies. So delivery room management is much more important. And another thing is in asepsis management in an unit. If you take care of an asepsis means, then you can read the beauty of an neonatology. If your unit has been what is called, if the unit has been managed well with an asepsis management means, then you can have a very good things. Whenever the delivery room management comes, TPS resuscitator comes means, not only TPS resuscitator, in neonatology, whenever the oxygen comes means, it is only in blended oxygen, not an whole oxygen. But whatever baby the device you use, either it be an TPS resuscitator or it be an CPAP, whatever things, it is only in blended oxygen is an, this is in neonatology, oxygen means it's in blended. Don't think that it is an normal oxygen can be given. But the thing is, to give a good outcome, all units, especially for a preterm, you can use an TPS resuscitator with a blended oxygen. So that's a main thing. So what is the importance of using a blender? Why everyone is giving a much more importance for a blender oxygen? Have you enlightened? Others can also contribute to answer.
To reduce the
And
incidence
prevent
of
free radical
bronchopulmonary
injury.
distress.
Pardon?
And prevent free radical injury caused by the oxygen. Sir.
Good, very good, very good. Then
To
It prevents
decrease the incidence of ROP.
ROP.
super. Not only it's an free radical injury is the main other things. So you can reduce the effects of an ROP, BPD, bronchopulmonary dysplasia, and decrease the number of stale. Everything is gives much more importance. If your unit been changing from using a blended oxygen, then the unit will be some mature unit. We can see much more babies coming out without any complications, going out without any complications. Okay, nice. So we have been discussed about things called respiratory distress. We can think about delivery room management and perinatal interventions. And another thing is things called jaundice. So we are told that the baby is on day 4 of life having a jaundice. So what would be the reason for this jaundice?
Now, she must also see that the term hyperbulimia means it's pathological. Hyperbulimia means pathological only. You can't put hyperbulimia and diagnosis as physiological. Okay. And two, physiological, if it were physiological, it need not be treated with phototherapy. So hyperbulimia refers to pathological jaundice. It is, you can't say it's probably physiological. Both the terms are contradictory.
So, okay, what are the causes for the jaundice in an preterm, this baby. What are the reasons? What are the causes for jaundice?
Sir, in this baby,
Image.
the RBC lifespan will be lesser, so there'll be increased hemolysis and increased bilirubin production might be there, sir. Then there'll be liver immaturity of the liver, so conjugation also can be defective, sir. In preterm babies, the enteral feeds are usually delayed, so that can be increased intrahepatic circulation also can lead to jaundice, sir.
Okay, this is a pathogenesis. What is the reason for this jaundice for this baby? In other words, what are the causes for the jaundice in preterm?
So it can be also due to sepsis, sir, in this baby.
Good. Then, see, this baby has been already, sir, is told, no, this baby, see, whenever the jaundice be there, it's only be an either could be an increased production or be an decreased excretion. There's only be an increased production or decrease in excretion. So, what are the reasons for an increased production in this baby? Increased production of jaundice.
Decreased RBC lifespan.
Okay, that's uniform to all preterm. This baby. See, already it's total, the baby is having an what is called that UGR. Wasted. Sir, sonangla, baby having an wasted appearance. What is the
Albumin.
Pardon?
Albumin will be low, sir.
Okay, fine. Albumin, but main thing in IUGR. See, the IUGR means it is an example of a chronic intrauterine hypoxia. If you are seeing an IUGR baby means it is a baby of a chronic intrauterine hypoxia baby. Definitely these babies will going to have an polycythemia. Definitely they will be in polycythemia. And some babies will having an thrombocytopenia also because of an hypoxia. The bone marrow will be suppression will be there, and because of this hypoxia, definitely there will be an erythropoietin level will be increase. RBC production will be there. These RBC volume can also add to reason for an production of an increase bilirubin. Number one. And prematurity, preterm will be and cause for an sepsis, it's a cause, is IUGR, IUGR baby, volume of cell volume is also being cause. And you have been clearly stated there is no any contusions or no cephalomotoma or caput. If anything these are present, all these also contribute to an increased destruction of this RBC. And another part is for increased production. Apart from this, what are the reasons for a baby to have an increased production, like any other baby?
Hemolysis.
Yeah, very good. Hemolysis. What would be the reason?
ABO incompatibility, G6PD disease.
Pardon?
ABO incompatibility, G6PD.
Yeah, what is meant by ABO incompatibility?
Mother's blood group and baby blood group. ABO.
Pardon, mother blood group?
Yeah, major.
Mother's blood group will be O.
Okay.
Positive, sir. And baby's blood group will be either AB or AB.
Baby blood group will be non-O. That's all. Okay, either be an A or be an. Okay, very good. Okay. Then other cause one is an AB incompatibility. Another one is an
RH incompatibility.
Okay. What would be a reason for an what is the pre-request for pre-setting for an RH incompatibility?
The mother's blood group will be a negative and the baby's blood group will be a positive, RH positive, sir.
Good, very good. So we can also expect an hemolysis. The two one we can also expect an alloimmune hemolytic anemia. Okay, good, very good. And any other causes apart from this will be added to an hemolysis?
Minor blood group incompatibilities.
Minor blood group. Okay, when will you suspect minor blood group? When will you suspect this ABO or RH incompatibility? On day 4?
On day 1 of life.
These are all pathological jaundice. Alloimmune jaundice or pathological jaundice. They will be presenting on day 1. These jaundice are presenting on day 1. Either it is an RH or an ABO or an minor incompatibility, it will be presenting on day 1, not on day 4. Okay, just asking what is the reason for the things. hemolysis. You have already stated good. It's an ABO. You have already stated good. It is an RH incompatibility is a cause for an hemolysis. And another also you have stated it's very good. It is a minor group. Any other non-immune?
G6PD deficiency.
Okay, good. G6PD.
Pyruvate kinase.
Hemolytic anemias, hereditary spherocytosis.
Sickle cell disease.
Now, sickle cell in a preterm and a newborn.
Hereditary spherocytosis, G6PD deficiency.
See, okay, in other words, what are the non-immune hemolysis can occur in an newborn? One is in G6PD, good. Hereditary spherocytosis, good. Then pyruvate kinase. Pyruvate kinase deficiency. See here, hereditary spherocytosis, definitely there will be an autosomal dominant inheritance. There will be in family history of an mother or father or an history that will be suggestive of an anemia or jaundice. And if it is an pyruvate kinase, that's an autosomal recessive. Siblings will be having an history of an jaundice or an anemia. In G6PD, maternal uncle is an X-linked dominance, X-linked recessive. So maternal uncle will be having an history of an jaundice or an hemolysis. Okay, these are all things, but these are all pathological jaundice, except immune-mediated jaundice aren't pathological. Will be presenting on day 1. Okay. You must also think that not only as like an only preterm or sepsis, more than that, it's an IUGR baby. Even an polycythemia, this cell mass can also contribute to an jaundice, and any contusions or any extravascular blood can also contribute to an jaundice, and RHI immunization. Okay, then, and apart from any other causes like treatable causes or preventable. Pardon?
Hypothyroidism for prolonged
Hypo?
jaundice. Thyroidism.
Yeah, good, very good. Hypothyroidism. We also think twice when we have been, the jaundice has been prolonging, which is not responding to it only phototherapy. It's having an recurring dates. We have prolongation of jaundice is there. Then also you can think of an hypothyroidism. But now we need to have a screen, and within 48 hours you want to screen for an hypothyroid. If it is a preterm, you want to screen it after 2 weeks also. Even if it is a 48 hours screening is normal, then you want to repeat it after 2 weeks also to make sure that TSH and 3 to 4 are normal. Okay. And what are the treatment modalities available for the neonatal jaundice? Okay, before you know that I elaborated the causes. Now, another thing, how will you decide the treatment? Which treatment is required for this baby? What are the things? What are the parameters, or what are things you need to decide the treatment? What treatment the babies need? Which baby needs no treatment? Which baby needs any other treatment modalities for
Yes.
jaundice?
All pathological jaundice needs treatments.
Yeah, that's okay, man. But what are things? What are
Based
the
on the charts.
Bhutanese normograms.
Based on the
What
Bhutanese
normogram?
our specific
Bhutanese our specific
Bhutanese normal.
For
normogram.
term babies, it is
Bhutanese is for an
term babies.
term baby, that also for an, it is an to decide whether to discharge a baby. It is like for assessing who the baby is requiring admissions. That's all. This is not to say this baby needs phototherapy and all. It is only to tell which baby needs to get discharged. It is a pre-discharge bilirubin normogram. So pre-discharge bilirubin, which baby can be discharged today, and which baby can be discharged or need to wait, or which baby after discharge, which baby comes within 24 hours, or which baby need to see after 48 hours. This is in Bhutanese is in pre-discharge bilirubin things assessment. That is only to decide the discharge, not to decide that is in a postnatal ward. That this Bhutanese chart is used for postnatal wards, that to decide the discharge and when to follow the baby. That is the utility of a Bhutanese chart. Treatment decision is by not by
Mason's
Bhutanese chart. Pardon?
Mason's chart for preterms.
See, now it's a nice guidelines give. Nice guidelines give him preterm. For a term, it is only an AIP chart. We will be still using an AIP chart. So now it's giving an nice guidelines where we can get an with the gestation age. gestation age, or it's on weight. Previously, we've been using an weight-based chart. Now we are using a gestation age chart with days within 24 hours, within 48 hours, or within 7 days for an phototherapy as well as for an exchange transfusion. Okay. Regarding an what is the things, because this baby has been also had an preterm, having an entity called an lethargy, and also having an jaundice. Then what is called an low bilirubin encephalopathy.
Acute bilirubin encephalopathy is the neurological manifestations.
See, it is an acute, that is called bilirubin induced neuronal dysfunction or an acute bilirubin encephalopathy. That's the things. What is the scoring system to assess it? That is for a term baby. What is the scoring system? That's a
Vine score.
It's the Vine score. We can able to assess for a term baby. I'm just asking, what are the causes for a low bilirubin encephalopathy?
Acidosis.
The blood-brain barrier and the
asphyxia.
Yeah, see, whenever
barrier for
the bilirubin is to be pathological, because it's within a normal limit, it doesn't need any treatment. It's only after some conditions only baby needs we need to treat it. In certain conditions like is a bilirubinic acid, bilirubin is a bilirubinic acid. If it is going to pass to an blood-brain barrier, means either the blood should be in acidic nature, because this unionized form of bilirubin will be passed easily to the blood-brain barrier. Either the blood should be in acidic nature, or the blood binding form should be replaced from that albumin. So if bilirubin will be binding with an albumin, either if the albumin is very low, or it is easily replaced by an
Acidosis.
substances
Free
from
fatty
the
acids.
albumin, or if the blood is in an acidic manner, or if the blood-brain barrier is being breached, then it is easy for that bilirubin to cross the blood-brain barrier and to hit the brain. So here the condition is that blood-brain barrier breach can occur in any form of sepsis, and blood acidemia, it is in form of any acidemia, any acidosis, like shock, any form of acidosis or hypoxia can produce any hypoxic, what is called an acidic nature of the blood, and low albumin, as in preterm itself have been low albumin state. And another reason, drugs which displaces the
Albumin binding.
bilirubin from the albumin. So these four will
Ceftriaxone.
hindrance or fastens the bilirubin to attack the brain. So usually it will be in a very low level itself. These preterm babies will be had a brain injury. So we must be very careful in treating a baby, especially preterm, having with lethargy and jaundice. Because lethargy may be due to any infection, or lethargy can be due to any hypoxia, hypoglycemia, and this lethargy can be also an effect of an low bilirubin encephalopathy. So whenever there be lethargy is in a preterm, especially with the jaundice, being very aggressive in managing and looking for these things, like how is that maintaining the perfusion, maintaining the oxygenation, maintaining the glucose status, and maintaining that stabilizing the babies, give her much more priority, and stabilizing the temperature, because persistent hypothermia per se can cause an acidemia. Okay, so you be very, very careful in handling the baby. Anyway, okay, decision is taken by an nice guidelines. And what are the treatment opportunities?
phototherapy, sir, exchange transfusion, and medical management.
Medical management. What medical management?
It is not approved, sir, but drugs like phenobarbital can be given, or metaloporphyrin.
If you prescribe phenobarbital for an jaundice, neonatal jaundice, you will be sued. If you have been using an phenobarbital for a neonatal jaundice, you will be sued. Because phenobarbital, okay, fine, it can increase the enterohepatic cycle, it can increase the enzyme level. Recent guidelines is very clearly stated that it decreases the baby, it makes the baby lethargic, and it decreases the sucking at the breast, it decreases the milk intake and more complications towards an effect of an phenobarbital, then it is having produced much more advantages for an jaundice. So treatment of jaundice is very clear. It is only an phototherapy and it is only an exchange transfusion. No more drugs is there. Even for an immune mediated, we can go for an exchange rather than going for an IVIG. Even now, recent guidelines clearly stated that IVIG is also moving out of what the treatment modalities, only in phototherapy and then exchange transfusions. And don't ever take go with a notion that prescribing a phenobarbital for an jaundice. That's not an evidence-based thing. Even it is going to have a much more adverse effects on an baby. Regarding phototherapy, what are the things? What is called an intense phototherapy? What is called a normal phototherapy? When will you go for an double surface phototherapy? When will you go for single surface phototherapy? When will you go for double surface phototherapy? What is called intense phototherapy?
Intensive phototherapy, except for breastfeeding, the infant should be in the phototherapy chambers.
Pardon?
Except for the breastfeeding, the baby should be in the phototherapy chambers.
See, it's like intensity means it is related to one irradiance level. Okay, intense phototherapy means it is related to one intense irradiance level, not related to one breastfeeding or anything. All babies on what is called on phototherapy should be within in a breastfeeding. Okay, only if it is not in a breastfeeding, then we can go for an IV fluid. In phototherapy, you can give an extra feed. That means we can also express the milk and we can give it to the baby. That's for number one. And when will you go for a double surface phototherapy? Any value 2 milligram below the exchange range, within 2 milligram below the exchange range, then we can go for a double surface phototherapy, double surface phototherapy. And whenever if okay, fine, in a term baby, okay, fine, we will be assessing with the bind score and also assessing for an exchange transmission. In a preterm, if the baby is lethargic, make sure that stabilize the baby and frequently assess the baby. And because this low bilirubin encephalopathy may be the reason for an lethargy. And another one is an exchange for an double surface phototherapy. Any value within 2 milligram of an exchange range will start on double surface phototherapy. And for exchange, any neurological signs within the exchange range, then go for an exchange transfusion. Okay. Okay. For this baby, can I have what is the blood group of the mother?
The blood group of the mother was B positive only, sir.
Okay. Blood group of the father?
Father also was B positive and the baby also was B positive.
Because if a blood group of the mother is okay, if it is a non-O or non-RH, then it can be very safe that we are not been dealing with any RH incompatibility or ABO incompatibility. And moreover, the jaundice has been developed on only day 4. It is not an pathological. It will be related to either of an increased production, related to an polycythemia of IUGR, or it related to only in preterm. Okay, or BN sepsis. That may be the reason for this preterm. Okay. Sir, Saravanan sir, can you add on any other?
You told
What is
about
the-
babies having IUGR. Also, can you highlight the difference between SGA and UGR?
Not audible, sir.
Can you tell me the difference between SGA and IUGR? SGA and IUGR.
Sir, SGA babies are more prone to have hypothermia, respiratory distress syndrome compared to IUGR babies. Then in IUGR babies, polycythemia can be a feature. and the SGA babies that can or may not be present.
Have you done ponderal index for your baby? CAN score and ponderal index for your baby. Have you done it?
Sir,
Have you done CAN scoring and ponderal index for your baby?
the CAN score we did not do, sir.
Have you applied ponderal index?
Sir, as the baby was appropriate for gestation, I did not do ponderal score.
Okay, doctor. Okay, doctor. Whenever you've been taking care of an preterm, and what are the complications early complications you can expect with preterm, and what are the late complications you can expect with preterm?
Early complications in preterm, respiratory distress syndrome, sir, intraventricular hemorrhage, hypothermia.
Just tell with a common to an uncommon. Common will be in what is called hypothermia will be in common.
Hypoglycemia.
Hypothermia, hypoglycemia,
Hypoglycemia.
Metabolic
Hypocalcemia.
complications. Yeah.
metabolic complications.
See, we tell either system or system wise from head to foot. Early and late.
Respiratory system, we can have a respiratory distress syndrome. In
CNS, we can have intraventricular hemorrhage, sir. In respiratory system, we can have respiratory distress syndrome. In cardiovascular system, we can have patent ductus arteriosus, sir. Then in GI, we can have necrotizing enterocolitis.
Ocular,
long-term
we can have
complication.
ROP, and long-term complications can include.
But I can't understand. You just talk loud. I can't understand it.
Ocular complications can include ROP, sir, retinopathy of prematurity.
Okay, fine.
And long-term bronchopulmonary dysplasia can occur in preterm babies when ventilated for long.
So, what is meant by called osteopenia of prematurity? So, whenever you are been dealing with, whenever you have been handling in preterm babies, you must know about these long-term complications, much more things like management of BPDs and osteopenia of prematurity and anemia. These things we need to know much better than when we are handling these preterm babies, because it's not like an only acute. You can managing and extubating the baby. It's okay, fine, good. After that, long-term management of the preterm is much more important. Especially, you must know about things called what is meant by osteopenia of prematurity.
Osteopenia of prematurity is due to undermineralization of the bone. There will be reduced serum calcium levels and serum phosphate levels, and increased alkaline phosphatase levels.
See, single most issue is there's a problem related to phosphate
deficiency.
So how we are going to prevent it?
By giving calcium and phosphorus supplementation to the babies.
Whenever the babies reach the full feed, supplements within calcium, phosphorus, and vitamin D. That's all.
Calcium
and you can able to assess it periodically, like usually we'll be doing it by 2 weeks to assess a screen for whether there is an hypophosphatemia, to have an issue related to this osteopenia. Don't think that osteopenia means the baby will have only and things related to one bone. Usually the baby will be lethargic, and also decreased activity will be there, and decreased abdominal sensation will be there, and they will be mimicking like an feed intolerance and mimicking like an apnea related to one sepsis. We are putting the baby on screen for all the things. We will be getting a negative screening, and the issue is related to one only and phosphorus and anemia. So do these two things in long-term management of an preterm. When come to an okay, this baby is having an injury, having an one lethargy is there, and what are the things that we can do for this baby to having a lethargy? So how will you diagnose and when will you screen for an sepsis? When will you screen for an sepsis? How will you interpret a sepsis screening?
Clinically, if the baby has lethargy, irritability, or apnea, feed intolerance, hyperthermia, with seizures may or may not be there, irritability may be there. If these
So the
features
sepsis
clinically,
screening means sepsis screening means whether to it's different for early onset and late onset. Okay. So if you what you are going to deal it, if you are dealing with an early onset means that approaches will be different. When we've been going to manage an late onset means that approach will be different. So we must able to have a clear cut things for early onset. So the sepsis screening for early onset sepsis, the sepsis screen is to when to say that whether we can withhold antibiotic or not. Okay. So to start an antibiotic, we doesn't know to looking for an sepsis screen because there is a foul smelling like and the baby is symptomatic. We can proceed to start an antibiotic. There is no point in screening for that. Having in 2 risk factors, you can go and start the baby directly. This sepsis screen only when we having a preterm premature rupture of the membrane and the baby is stable, then we look for an sepsis screen to substantiate that not to start an antibiotic. That's all. Sorry. So not to start an antibiotic, when to whether the babies we can withholding the antibiotic is justifiable. For that we can doing an sepsis screening for an early onset. In a late onset, that also once again, if it is like simple things like only one feed intolerance or one apneic episodes, okay, we can wait. We can do on screen and we can. We having multiple things. We have been established like full-blown feed intolerance with abdominal distensions, with 2 or 3 things with apnea or the lethargy with some perfusion abnormality. Then we can go and start an antibiotic. Don't wait for an septic screen to decide you are starting an antibiotic. So deciding antibiotics depends upon the clinical settings and then background information. This is only to say to withhold the antibiotic whether we are justified before starting an antibiotic or not. That is the reason only to do an septic screen and all. Okay, here the baby is having an or lethargy but not having any seizures or not having any apnea. Okay, so what are the investigations we can do at that point of an apnea to see, because in the courses you were told that within 6 hours you have taken an oxygen, and day 2 itself I think you have started on KMC. Yes, I am correct? Yes, I am correct? Day 2 itself I think you have started on KMC and started on Paradai feed, and day 3 the baby's got an lethargy. At the time you diagnosed an hypothermia, hypoglycemia. Okay, with hypoglycemia, what you have been giving? You are giving only feed or fluid or both of it? For hypoglycemia, pardon?
Feed and fluid was given, sir.
Feed and?
Initially, fluid.
Initially, fluid.
Sir, initially the baby was given 2 ml per kg bolus correction, sir. Then the baby was, since the baby had a refusal of feeds, it was started on glucose infusion. And then the baby improved and started taking Paladai feeds, sir. And it was the glucose infusion was gradually tapered and stopped, sir.
Ideally, when will you start? What is the indication to give an IV fluids, and when will you indications to give an IV bolus?
Whenever the blood glucose is less than.
Pardon?
Whenever we have hypoglycemia along with symptoms.
Along with?
Symptomatic hypoglycemia, we will give bolus.
The only 2 things, symptomatic hypoglycemia, we can give an bolus and start an IUGR. That's number 1 things.
Yes, sir.
If it is not symptomatic, then when will you give an IV?
Whenever blood glucose is less than 20, we can give IV fluids.
Even after trial of feeds, if the glucose is not
Yeah.
improved,
First of all, you given less than
trial
20.
after a trial of even after less than 25, you can give a trial of feed, oral feed. After an oral feed, then we can give an then the persistently the baby is having low glucose even after trial feed. Then go for an G. It's very good, nice. And here regarding an sepsis, what are the investigations can give to diagnose screening test to say the baby is having a sepsis? What are the parameters you can take into account to say the baby is having sepsis in a sepsis screen?
sepsis screen, we have CRP, micro ESR, immature to total neutrophil counts, and absolute neutrophil counts. In the CRP should be more than 1, micro ESR should be more than 15 millimeters. Then absolute neutrophil count should be based on the Musingo chart for preterms, and immature to total.
See, there is one thing called an most commonly used test in all units, and the thing is called an some tests won't be done in many units. Okay, I think that everyone will be doing an CBC and CRP.
CRP.
So you've been based upon these two, because many units, some units will be using a micro user, but many units I won't think that it is commonly used in across the units. Many of the things are not using micro user, but CBC and CRP will be everyone will be using, and you can tell with these things what are the things to say it is an favoring for an sepsis, or in CBC what are things we can get a clue?
In CBC,
When you have
neutrophil
leukocytosis with
or
the thrombocytopenia.
also can be present, sir.
Leukocytopenia will be giving much more value than an leukopenia, low WBC count giving a much more value than an high WBC.
WBC count.
There will be a normogram to assess things whenever there is a high, and absolute neutrophils also it's very good. And regarding CRP, which will be much more important, positive CRP are more important or negative CRP is more important?
Negative CRP.
Negative CRP will be more important, sir.
The thing is, positive CRP means it may be also be an infection, but it's like any inflammation, even in meconium strain like or injuries, we can have an increase in CRP. But negative CRP is much more important. So negative predictive value of one semi-septic screening is much more valuable than a positive screen. Especially for leukopenia with CRP positive, okay, we can go in favor for an sepsis. Rather than sepsis, to say it's not an infection. Two values 12 hours apart, two CRP values 12 hours apart. If it is negative, damn sure that you can say that it is not the problem is not related to one infection. So negative predictive value is much more important to in the sepsis setting. Okay, any other test we can do it whenever the baby is having this lethargy or lethargy, jaundice with hypoglycemia. Pardon?
Blood culture.
Pardon? I can't understand.
Blood culture, sir.
Yeah, blood culture. What would be the yield on getting a blood culture to have an positivity? Usually less than 20%. Within 20% only we can get it. What are the organisms most commonly we can have in an early onset or late onset? What are the most common organisms we can get?
Gram negative organisms.
Organisms.
Especially gram negative, especially.
Klebsiella.
E. coli.
Klebsiella.
E.
Commonly
coli.
we can get Klebsiella. Klebsiella is the most common. Then we can have things called an Staph aureus. Okay. Then Acinetobacter and all that will come later. But commonly we are getting an Klebsiella. Fine. And anything related to one things called an blood culture. What is the latest technology using to do an blood culture?
Backtech method.
Okay, we can get it within 24 hours. We can get a report within. Because many a time you get in blood culture, and if you're getting a report on fourth day, by the time we can, what is called, we cannot maintain the baby in things, but waiting at blood culture report. The thing is, what the thing is that you can use you need to have your unit should have an antibiotic policy. So what is the first line? And you should be audited with that previous 1 or 2 months, or 2 years, or a previous
Yeah.
6 months blood culture reports. You must have an antibiotic policy, and you must having in first line, second line, third line, and what are the most common organism you unit have, and you should have an first line, second line, third line. Based upon that, you must escalate or de-escalate, and also you can modify within blood culture report. If it is in black type, you can get it within 24 hours or maximum 48 hours. You can get that even culture and sensitivity. If it is in a routine, we can take it at 4 days. It's huge time for an making the decision. So that you must kept in mind whenever you are releasing the blood culture report. When coming to an any other investigations, okay, blood culture, okay, then okay, any related to neurodevelopment outcome?
Lumbar puncture can be done for ruling out sepsis.
Okay, lumbar puncture, it is, what is the indication to do on lumbar puncture?
Late onset sepsis, features of lethargy, irritability, seizures.
Yeah, anything related to having any CNS symptoms, or you are having any culture positivity, or you are having any CNS symptoms, then we can go for an what is called CSF analysis. Okay, what is the upper limit of in a CSF analysis? What are things we are looking for?
We look for cells, then sugar, protein, and chloride, sir. Then
Sugar, cells, okay, sugar,
Sugars.
proteins, and culture.
Culture.
What are things you're looking for it? In sugar,
Cells.
what is the clear?
Sugars, if it is CSF sugars, and the blood sugars should be, if the CSF sugar is less than 2/3 of the blood sugar, then can consider as significant.
Fine. Now the recent guidelines clearly says, because without much more importance to one sugar, give importance to the proteins and then cells. Recent guidelines is clearly states give importance more towards on cells and then proteins rather than sugar. Okay. When come to on jaundice, it's a general question, not related to here, because these babies are having an preterm hypoglycemia, lethargy, and jaundice, and any other importance other than an CSF, any other investigations when corrected with the corrected gestation age, or the babies reach the term. Any other
Sir,
investigation?
ultrasound cranium.
Ultrasound cranium, it tells only two things. One is whether the way having a hydrocephalus or having an IVH. That's all. Nothing you can get it more than that in ultrasound.
Fundus examination.
Yeah, that is a fundus is an ROP screening. It's come to an screening part. That's a different one. I am asking him, any other investigations can be done in that, when the babies reach the term age. Say MRI brain. So we need to look for an MRI brain. Okay, because having an things called hypoglycemia is there, the baby is having an lethargy is there, and also having an jaundice. But okay, fine. So you do what will be the MRI finding whenever a baby looking for an hypoglycemic induced braining?
There will be white matter
White
injuries.
Area of preference.
Parieto-occipital regions.
Yeah, parieto-occipital. Usually these babies that gives an neurodevelopmental prognosis to say the prognosis of the neurodevelopmental outcome. At the term age, corrected age also, we must assess that neonatal neurological examination. Your neurological examination at this point of time is okay, fine, good, but you must also repeat it by the term of. So what is PVL? Preventive leukomalacia. Anything related to anything related to an age or this PVL?
Sir, periventricular leukomalacia occurs because of white matter injury near. Sir, periventricular leukomalacia occurs because of white matter injury located in the periventricular region. Any history of ischemia or hypoxia during the
it is usually the sign of an in utero hypoxia. One or second one is in ex utero. It may be in any other effect of an hypocarbia.
Hypoxia.
Hypocarbia. That means you've been overventilated. Carbon dioxide washout would be a reason. Because whenever this preterm with IUGR, especially in MRI also, you must looking for this periventricular leukomalacia, number one, to have any neurological outcome. Especially it must be concentrating on lower limb physiotherapy to make the baby prevents and lower limb contractions. And another thing is, if the baby is also ventilated also, you must be look for this periventricular leukomalacia. Sometimes if the periventricular leukomalacia has been so severe, it can form the things called an porous form. That's encephalomalacia will be there in a severe form. Then will be a very poor neurological outcome. So whenever you have been seeing with the preterm with IUGR, you must think of it. It would be it's a case of an intrauterine hypoxic case. You must also think of at a term age. You must look for an MRI, number one, and also you must, when a baby is ventilated, you also think it is an look for an MRI at a corrected age. That corrected term, at the corrected term age, you must also look for an MRI. Okay, another question is related to one jaundice. So it's a basic, it's a common questions. What is mean by an breast milk jaundice or an breastfeeding jaundice?
Breast milk jaundice is due to inadequate feeding. It usually occurs after during the first week of life, and the breastfeeding should be continued, and it will gradually settle down by 2 weeks. Breast milk jaundice is due to beta glucuronidase present in the breast milk. For this, if we stop the breastfeeding for 2 days, the jaundice will subside.
Which milk will we give after you are stopping your breastfeeding? So if the
Breast
values
milk
go
jaundice.
more than 25 only, we can be able to stop on breastfeeding. That too temporarily, not a permanent. If the values goes more than 25, before that there is no need to start even for a breast
Milk.
Breast milk jaundice. See, usually breast milk jaundice, it will occur in a second or third week. Usually in a thriving baby. Baby weight gain will be good. So baby weight gain will be good. It will be occur in a second or third week in a well-thrived baby. Okay. In a breastfeeding jaundice, it does occur in an early stage within a second or third day. Usually it is an weight loss babies. So the differential diagnosis itself very clear. If you're seeing any baby less than a week with weight with inadequate weight gain, then you have been dealing with an breastfeeding jaundice. On the other hand, if you're dealing a baby, no jaundice in an perinatal period, and you are having a jaundice on second or third week in a weight gain baby, then we are dealing with only a breast milk jaundice. That too, in breast milk jaundice, don't ever stop a breastfeeding. If you are with the milk, if you are giving a milk more than an bilirubin level, if it is more than an 25, then only we can able to stop an temporarily interruption of an breast milk is indicated. Till then, no need to stop an breastfeeding.
Your case, could it be breastfeeding jaundice?
Yes, sir. Because the breastfeed was established only on day 5 of life, sir.
Okay. What is the birth weight of the baby and what was the weight on 7th day?
Birth weight was 1,460 grams, sir.
1,200.
1,420 grams, sir.
What is the weight on 7th day?
1,260, sir.
So what is the percentage of weight loss this baby has gone through?
11% weight loss, sir.
It's normal?
Yes, sir. For preterm babies, it is normal, sir.
Now, that is why important. This is not just a preterm. This is an IUGR on a preterm. So this baby, you should not permit it to lose weight at all. Understand, this baby is born with less water content because of its IUGR nature, less body muscle mass and fat mass. So the water content is less. So the regular weight loss that you see in AGA babies, you should not permit it here. So that's one of the reasons this baby goes for jaundice also. Okay, what happened? Did the baby at the time of discharge start gaining weight?
Yes, sir.
So you have established weight gain in this baby.
Yes, sir.
Okay. And thing is, only two more questions from my side. The one is, what are the supplements we'll be using to this baby? What are the supplements?
Sir, HMF fortifier.
HMF fortifier.
Human weight 45 HMF.
HMF sachet.
See, there are some indications when to start an HMF sachet, not for all babies. What are the normal supplements we will be giving for this preterm babies?
Calcium and phosphorus, sir.
Good, very good.
We can give amino
Calcium and
acid.
phosphorus. Then,
By 4 weeks of age, we can start.
Multivitamin.
whenever the baby reaches full feed, then we can start on supplementations. Supplementations only we are going to give us an multivitamins, calcium, phosphorus, and iron. This is only the supplementations we are going to do. So iron, it's only when it is reaches the 2 weeks. After 2 weeks only you are going to give an iron. Before that, once started on full feeds, you are going to give only an calcium, phosphorus, and multivitamins. So calcium, phosphorus means, so usually what are the dose you can give at calcium or phosphorus?
Calcium phosphorus ratio should be 1.62:1 to 1.4:1.
2:1 ratio. Let's leave it,
2:1.
man. What is the dose?
Calcium at 120 to
What is the dose?
160 milligram per kg, sir.
Get it any one value. Put it in 40, 140 or 70 phosphorus. Okay, fine. Okay. So calcium phosphorus, multivitamin, okay, 0.5 ml. And iron after 2 weeks, it's only going to be in 2 to 3. Because why I am giving stressing much more importance here, that too for postgraduates. Whenever you are discharging a preterm baby, you must have a think that you in a discharge checklist, you must check that these babies had received these supplements so that it won't land up in an EUGR, extra uterine growth retardation, or osteopenia or anemia later. Because these anemia and osteopenia make the baby sick in a community, and we find it sudden death in a home, and everything was related to this inadequate supplementation to the baby. And also inadequate weight gain is also related to this baby. Inadequate weight gain is also related to this not giving the supplements. And another thing is, what are the screenings you will do before this preterm babies get discharged? Or what is our screening checklist you will follow in your unit before discharging and preterm?
The baby should have adequate weight gain, sir, of 20 to 30 grams.
What weight gain?
20 to 30 grams per day.
Okay.
For 3 consecutive days.
Then, okay, the adequate weight gain, okay, for 3 consecutive days. Then,
Mother should be confident of taking care of the baby.
Pardon?
Mother should
Pardon?
be confident of taking care of the
yeah,
baby.
mother should be confident, and mother should have thought of a KMC, asepsis, and exclusively breastfeeding, especially breastfeeding of an hind milk extra EBM. Hind milk EBM is much more important because giving an 4 milk only, it's won't going to get the weight of the baby. Giving an hind milk EBM is much more important, especially for an preterm baby. So breastfeeding, confidence of the mother, asepsis routines, and hind milk EBM, giving and supplementations, KMC care, and temperature maintenance of the room. How you are going to, you must make sure that adequate temperature maintenance. So we have 2 sets of climates. In summer, you should also tell that temperature maintenance, and also in winter, you would still how the temperature maintenance. What the textbook says that putting at shutter, putting at cap, and everything is goes to an cool climate. But when come to summer, it sounds good. You must tell that adequately. If you find that when the room is fit to, you itself think that when we are able to live in the room in comfortable things, then you can also maintain it for the baby, and you put the KMC at that room. That's very, very important. Okay, temperature maintenance is much more important. Then what are the screening you will be telling?
Hearing screenings.
OAE
OAE and
for a preterm. Okay, when the baby reaches term, okay, you can go for an OAE. Then
retinopathy of
ROP
premature
screening.
when you are going for an ROP screening.
all babies less than 34 weeks or 1.5 kgs, or if the baby has any
Indian
history of
guidelines.
sepsis.
Indian guidelines. Indian guidelines clearly states that
34
all
and
babies
2 kgs.
less than 2 kg,
2 kgs.
less
2
than 2
kg.
kg
2 kgs.
or less than
Less
34 weeks
34
compulsory will go for an ROP screening. And babies less than more than 34 weeks or less than 37 weeks, they having a stomachos requiring oxygen or ventilation, giving in surfactant.
Phototherapy.
Then
transmission.
these babies also went for go for an ROP screening. When will you do for an ROP screening?
Uh,
2 to 3 weeks of
So-
Which baby needs 2 weeks and which baby needs 3 weeks?
At before 28 weeks of gestation, if the baby is born, then
Whenever
3
the
weeks
baby
of,
is, whenever the gestation age is very low, you should also
3
see
weeks of
very early.
post.
That means because these babies will go for an APROP, aggressive posterior ROP. So whenever the age limit is low, less than 28 weeks, you should be screened for an at 2 weeks of postnatal age. Rest of the babies will be seen by 21 weeks. In the discharge summary, you should also write it when they have done an ROP screening or when they should come for the follow-up for that ROP screening in the unit. That you should mention in your discharge summary. That's very, very important. And also you should be, if the mother is not turned up for that day, you should also phone call it and remind them to come for that ROP screening for the next week. That's very important. Then, any other thing?
Vaccination should be given.
Yeah, before discharge, okay, fine. You can give an okay, BCG, OPV. If the weight is more than 2, then you can give foreign things. And you can also tell about post-discharge follow-up. You should also integrate these babies post-net after discharge. You should integrate with your local health system like VHN or local things like ICDS. You should also integrate them to take care of that any minor elements or taking care of any breastfeedings or hand hygiene. And you make sure that this baby come to your follow-up at a prescribed term. For a preterm baby, they should have first visit by 5 to 7 days. Then we can go for an weekly or 2 weekly, depends upon the nature of that weight gain. Okay, these things you should be tell to the babies before discharge. If you follow it, definitely these babies won't go for any other issues. And once again, whenever you go for an weight gain, if they doesn't have an inadequate weight gain, then even after supplementations, that calcium, phosphorus, and iron, if your baby is not getting weight gain, then you can go for an HMF. Because the cost of an HMS is huge. You can 13 rupees for an each sachet for 25 ml. If you are giving an one sachet, the baby is taking in 20 ml, 25 ml feeds for an 8 feeds. The cost comes around an got like 13 into like 8. So which is a huge amount for an that poor family. So you take HMF will be an option when there is an inadequate weight gain when the baby is after supplementations. And another thing is called there's a low cost and high effective interventions KMC, as well as an things called a massage, oiling massage by a coconut oil massage. And this can given coconut oil like not 2 drops even by mouth when the you add it to the milk and can given when there is an inadequate weight gain. So low cost, high effective intervention is one is KMC and another is an oil massage to have a good developmental outcome and good weight gain. If you are giving a body massage, then it also improves the stimulation, early stimulation for the baby and gives much more neurodevelopment outcome. Thank you for your things. And sir, any other things can contribute, sir?
Yes, and this just to say, add a few, 1 or 2 points regarding the role of phenobarbital in neonatal jaundice. In phenobarbital, there is no role for routine use in your neonatal jaundice, where mainly it is due to hemolysis, AB1 RH incompatibility, but there is a small sect of condition where you can use phenobarbital reserved, like for Crigler-Najjar syndrome. There's the only drug that is available to treat. And there are few conditions of unexplained unconjugated hyperbulimia where phenobarbitons are used. Other than that, in your regular practice of neonatal jaundice, either physiological or hyperbulimia due to RH and ABO, there is no role for phenobarbital. That we need to understand. And he is restated that breast milk jaundice most often settles over time. You need to only reassure, and the need to stop the breast milk doesn't arise unless the levels are capable of causing bilirubin encephalopathy. He has rightly put it. Then you must also see to that the graph that is being displayed on the slide, this showing this baby is IUGR, because the various parameters of weight, height, and etc., all of them fall on different percentiles. That itself indicates this baby that is IUGR. And IUGR babies, you must take care to see that you do not push them into EUGR also, extra uterine growth retardation. That's also very important. And he touched on which babies to start on presumptive antibiotics, where there are risk factors for sepsis, whether we need to wait for sepsis screen or not. When no clinical features, probably you can wait for nowadays sepsis screen takes very less time to get the reports, because you need to decide whether there is a need to start antibiotic or not. But when clinical features are there, you should not wait for the reports. You have to start your presumptive treatment. I think he has reinforced all those points correctly. Then neonatal screening for OAE like ROP is also important. All the neonatal screening that is done should also be done for any preterm graduate that is going out to nursery. He has touched on the protocol for ultrasonogram, protocol for graduates of preterm babies. I think he has touched almost all the points that goes to for a preterm care, apart from jaundice also. Thank you, Sendil.
Thank you, sir.
Yeah. Thank you, Dr. Dhanisha. Please stop slide 7. Yeah, and really wonderful case discussion by Dr. Senthil, Dr. R.S. sir, and Dr. Saravanan. And I invite comments from our judges. Dr. Ramesh sir, please.
Excellent, sir. Today is a very nice presentation. It is a very comprehensive, complete, perfect discussion on newborn as well as preterm. They did, especially Dr. Sindhi did a wonderful job of mixing nicely theoretical aspects as well as practical aspects. The chairperson also gave his expert comments, and the students did extremely well. Single-handedly, Dhanisha is able to answer all the questions, ably supported by her colleagues. It was a very smooth sailing for everyone. And I'm happy that Sendil emphasized the importance of temperature maintenance. I also insist in a place like Tamil Nadu, it is always hot, hotter, and hottest. We don't have a cold climate like in the West, Europe or US, where it ranges anywhere between -2 to plus 25 degrees centigrade only. Whereas for us, it is from 30 to 40 only sometimes. So in the summer also, because of emphasizing on temperature regulation, I see children brought from nursing homes for fever. They will be having a cap, socks, and everything is nicely covered, 2-3 layers like they do in foreign countries in cold climate. I think it's nice that you emphasize that point, because they have to be reasonable and very practical also. The baby, it should be slightly discomfort for us. That's all. Otherwise, summer there is light cotton clothes should be good enough. And another important point they emphasize about the controversy about phenobarbital. Another excellent. Even now, a lot of pediatricians use phenobarbital for jaundice, and as a chairperson, Dr. Arslan mentioned, so only very few conditions like regular Nagar and RF. It is progressively unconjugated the jaundice. You are going to use it. Otherwise, it has no role in physiological jaundice. Thank you, sir, and the whole the moderates did a good job, and Dr. Saravanan must be congratulated for preparing their PGs for a nice presentation. Thank you for the opportunity, sir.
Thank you, sir. Dr. P.
Thank you, sir. That's a real, very detailed discussion. And Senthil was taking them very nicely along with all the basic principles behind each clinical feature, sign, everything. And he was very supportive of the postgraduates. So that is, I mean, it's a very, very mature approach of a teacher. So congratulations and very well done, Dr. Senthil. So that's, I think the students must have learned a lot of good things today.
We also learned, sir, many things.
Yeah, of course. And Arasar in his, he has got so much of experience, the vast experience. And just a few important things when he said, they really hit the nail on the head. Okay, like example about the identification of an IUGR baby and what are all the special problems which you face in an IUGR baby vis-a-vis a jaundice. And these are all the practical aspects. And he also mentioned about the child with a increased temperature that also is giving rise to problems. Okay, so these are all the very, very practical and important things, and which you have to bear in mind, not only for your exam purpose, because newborns are going to be the major this thing for even pediatricians. Okay, even though we have a lot of very well-trained neonatologists, so we are the ones you have to take care and continuous care. So it's very important, and we keep learning from the vast experience of people like Professor Arasar. And thanks, Dr. Saravanan, for very well prepared and giving a good case. And I should congratulate the postgraduates. Danusha, you presented very well. The presentation was very comprehensive, and you didn't miss any point. So very good way you presented and good slides. And you also showed some photographs of the baby, the various neonatal reflexes, which was nice. And Dr. Prakash and Hariprada, I'm very happy to see them also enthusiastically participating. Usually just the presenter keeps talking. Here, all of you gave very good points. So well done. I'm sure that you will all do very well in your exams and future career also. Congratulations and best wishes. Thanks, IAP.
Thank you.
Thank you, sir. Yeah, I request Dr. Rama Chandramohan, madam, please.
Senthil, I've always seen you as my student. Today I've seen role reversal. You did an excellent job of going through the entire, actually a textbook on prematurity. I think we felt that we had revised the whole thing, and it was a very good session. Arasar highlighted whatever had to be at regular intervals. Thank you. And PGs, you did a very good job. So on the whole, it was a very, very interesting class. Thank you.
Yeah. Thank you, madam. And Dr. Arasar Sirala, sir, please concluding remarks, sir.
No, thank you, sir, for requesting me to chair this session and giving an opportunity, especially with all stalwarts also participating and contributing through chats and reminding us what should not be forgotten for discussion. I think the session went on, the postgraduate presented really well. And Senthil elaborately touched, as Dr. Rama Chandramohan told, today in relevance to the case that we have been discussing. I thank all the IAP office bearers and for giving this opportunity today to be a part of this.
Thank you, sir. And on behalf of IAP TNSC, I really thank Dr. Arasar Sirala, yes, chairperson. In spite of his busy schedule, I think he spoke by his Saturday practice also today. He has told a busy day. And I really thankful to Dr. Arasar Sirala, sir. Thank you, sir. I really thank Dr. As usual, he has discussed very nice case and pro PGs also. And really appreciated Dr. Senthil, sir. I think he's going to organize another state conference coming this September. I think wholeheartedly we have to support your endeavors, Dr. Senthil. And regarding this, you want to talk anything, Dr. Senthil? Yeah.
Sir, welcome to Trichy, sir. That's my request to everyone. Welcome to Trichy for South Neocon 2022 on September 22, 23, 24, 25. 22 is an workshop, 23 is CME, and 24, 25 is a main conference. I welcome you all to come, and our legends like Rama Madam and Arsar sir are giving an opportunity for me to done in Trichy, organizing it. And our IAP, so IAP and jointly with NNF, we have been doing it in Trichy, and NNF Tamil Nadu is giving it, organizing it in a big way. Come and grace the functions. I welcome you all in person. Thank you, sir.
Thank you.
This new look is for the safe delivery of South Neocon.
Sir?
This new look is for the safe delivery of South
Yes,
Neocon.
sir. Looking forward to safe delivery of Neocon. Yes.
Nice.
Yes, sir. The outcome will be good, sir.
Yeah, you'll be a very happy father.
Will be a term healthy baby, sir.
Dr. Saravanan, please. Yeah. Unmute பண்ணுங்க, unmute.
Saravanan, unmute. Can't hear
Unmute,
you,
sir.
Saravanan. Unmute.
Sorry, sir. Already you made us very special, especially super seniors are like you all. Even we learned a lot from you along with postgraduates. And special thanks to all, sir. Thank you very much, sir.
Yeah, thank you, Dr. Saravanan. Dr. Annamalai Vijayaraghvan sir is there. Dr. Annamalai sir. Sir, voice swelling, sir.
Can't hear you, sir.
Now,
Yeah.
thank you, sir. Thank you for the opportunity. I must first congratulate the postgraduates, Dr. Dhanushya, Prakash, Hariprada, for the excellent presentation today and answering the questions.
Thank
I
you,
must congratulate my former student, I can call, Dr. Senthil Kumar.
Yes, sir.
During his DM, I was also there. And he has done a good job, made us revise, as Madam has said, the entire preterm care, Jaundice. And of course, along with Dr. Saravanan, who had prepared the students very well. I must thank our professor, Dr. Arsar Siralar, who has summed up everything very nicely. The excellent take-home points he has stressed. I think the students must remember that. And everything he had touched. I am very happy to attend this. Thank you all.
Yeah, thank you, sir. And I really thank our judges, Dr. Rama Chandramohan, Madam, and Dr. Ramesh, sir, and Dr. P.S. sir, to be here for this assessment. And on behalf of IAP TNC, I thank all the postgraduates from colleges, Southern Medical College for this opportunity. And once again, I thank one and all for this excellent case presentation. And really, it's happy that all the postgraduate they answered very well. And really, hats up to Rajamuthaya Medical College students for this wonderful presentation. Yeah, thank you. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.